Welcome, everybody. We're going to get started in just about a minute. Let everyone populate the room from the waiting room, and then we'll get started. We have about 40 people in, so we can get started. So welcome, everyone, to the May Prep webinar on spirituality and psychosis. For those of you who don't know me, I'm Jen Sperduto, and I'm joined by my colleague, Dawn Reinhardt Wood, and we are from the Department of Psychiatric Rehabilitation and Counseling Professions at Rutgers and the Institute for Inpatient Psychiatric Rehabilitation. And we're joined today by our presenters, Miriam Diephouse-McMillan and Allie Van Kuiken, who are chaplains at Trenton Psychiatric Hospital in New Jersey, and I'll get to a little bit more of their information in a minute. This presentation is sponsored by the New Jersey Department of Health and the Department of Human Services and the Rutgers State Hospital Psychiatric Rehabilitation Initiative. So this is an interactive training, and we encourage you to ask questions through the chat box or the Q&A and participate throughout the session. Although for today's webinar, we do ask you to submit your questions, but we are going to hold them until the end and have a Q&A at the end of the session from starting at about 3:45. A recording of the webinar will be available after the presentation on the Rutgers IPR website, and Dawn's going to post that link for you. And at the end of the training, there'll be a link to a training evaluation, which will have the handouts, resources, and if you complete the training evaluation, you can get a certificate of attendance for being here today. Also, if you're going to put something in the chat box, make sure you change the audience to everyone. So if you want everyone to see your question or response, you can do it there and not just the hosts and panelists. Okay, some disclaimers. The Psychiatric Rehabilitation Education Program, or PrEP, is an online forum for a variety of topics relevant to state psychiatric hospital staff. And while Rutgers and the Division of Behavioral Health Services are co-sponsors of the program, the PrEP webinars are peer-presented, and as such, the content is independently developed by the presenters each month. The views and opinions expressed in the program are those of the speakers and don't necessarily reflect the views or positions of any entities they represent. As I mentioned, we are recording so that we can have an archive of this webinar, so just be mindful of that. I'd like to introduce today's presenters. We are thrilled to have the Reverend Miriam Diephouse-McMillan. Miriam is an ordained minister in the Presbyterian Church and a board-certified chaplain. She's been a full-time chaplain at Trenton Psychiatric Hospital since 2012 and enjoys helping patients explore how their spirituality impacts daily life and recovery goals. She specializes in DBT-based counseling and mindfulness skills and is currently writing a book on spiritual practices that support mental health. So welcome, Miriam. We're thrilled to have you. And the Reverend Allie Van Kuiken. Allie is an ordained Episcopal priest and a board-certified chaplain. She worked at Ann Klein Forensic Center and Capitol Health Regional Medical Center before coming to Trenton Psychiatric Hospital in 2021. She co-supervises the chaplain intern training program at the hospital and is working towards certification as a clinical pastoral education educator so that she can train future chaplains in that accredited program. So welcome, Allie. We are thrilled to have you as well. So ladies, I'm going to turn it over to you, and you let me know when you want to advance the slide.
All right, thank you, Jen. So our presentation today will explore the complex interplay between spirituality and psychosis. We'll provide a broad working definition of spirituality before diving into the ways that psychosis can impact spiritual expression. Next, we'll discuss how religious beliefs and practices can aid in coping and offer a framework for spiritual assessment. And finally, we'll share some case examples based on our own work with patients to help contextualize the discussion and highlight how chaplains navigate the complexities of spirituality and psychosis. And our learning objectives are for you to be able to identify internal and external aspects of spirituality, to understand potential benefits of spirituality as a coping tool, and to recognize the importance of culturally sensitive spiritual assessment. And we want to recommend to you some previous prep webinars that relate to our topic today. The first is Spirituality and Recovery from Grief and Trauma by Reverend Mark Stevens. He is a chaplain at Anchor Psychiatric Hospital. And that's a really good introduction to chaplaincy and spirituality for psychiatric patients if you're interested. And to learn more about psychosis, we recommend the webinar presented by Crystal Socha titled Engaging and Supporting Individuals Experiencing Psychosis. These are both prep webinars that are available if you go to the Rutgers prep webinar website.
Next slide, please. So anytime that we're talking about spirituality, I think it's really important to know what we're talking about. There's a lot of different interpretations and definitions of spirituality. So you will see on your screen, there is both a QR code and a link to a word cloud. And I would invite you to go to that word cloud and type in whatever comes to your mind when you hear this word spirituality. We want to get a sense of what you think spirituality is all about. Let Jen mastermind our word cloud for us. And the link is also in the chat if you don't have a phone to take a picture of the QR code. While she's doing that, just some interesting research to highlight as you guys are adding that. There was a research study done, and this is cited in a book called How God Changes Your Brain by Andrew Newberg. He's a neuroscientist down in Philly who does a lot of research on like doing scans of the brain during prayer and meditation. So one study that he cites talks about a survey where they asked 1,000 different people to describe a spiritual experience. And in the responses, there were over 5,500 different words used, and very few words were used in any more than 10% of the responses. So that just gives us a sense that like the wording around spirituality is very diverse. People have different understandings of it. So do we have the word cloud starting to populate here? We've got connection, faith, higher power, God. Faces in the universe, force in the universe. There's still more coming in. Mystery, I like that. Grace, comfort, meaning, spirit, non-self, love. And there may be more that are coming up, and you're welcome to keep the word cloud up individually, but we're going to return to our slides for a moment. But I wanted to highlight that it's really hard to talk about spirituality unless we know what we're talking about, unless we're all clear about our terms. So we can go ahead and go back to our slides, Jen. I want to talk a little bit about the terms religion and spirituality in particular. Some people assume that these terms, and we can go on to the next, thank you. Some people assume that these terms are very synonymous. Other people think they mean very different things. So one example is there's a lot of Pew research out about who identifies with what religious group. And they came up with the term spiritual, but not religious, to identify these people who are interested in spirituality, but don't affiliate with a particular religion. And then since then, they've been tracking the fact that unaffiliated is the fastest growing identity in terms of spirituality in the US. So that gets at this idea that for some people, spirituality is different than associating with a particular religion. For the purposes of our discussion today, we're going to use spirituality as kind of the umbrella term. And it encompasses, but isn't limited to specific religious beliefs and practices. So we have a working definition on our next slide that I will share with you. This comes from Kenneth Pargament. He's a researcher at Bowling Green University who works on sort of spirituality and coping. So his definition, and he does use the terms religion and spirituality synonymously, which I don't, but I do like his definition. So spirituality is the search for meaning in ways related to the sacred. And I want to unpack this definition a little bit because it's kind of, even the words are a little bit churchy sounding at times. But this idea of the search for meaning, we know as mental health professionals that making meaning is a part of the human experience. I have a 5-year-old at home, and he is very fond of the question why, right? We all go through this phase as children, understanding why the world is the way it is. You may also be familiar with Viktor Frankl, who is a Holocaust survivor and a psychologist, who writes a lot about how crucial the search for meaning is in human life. That in the concentration camps during World War II, the difference between those who lived and those who had trouble surviving was those who had a sense of purpose, a sense of meaning. So it's so fundamental and crucial to human life. There's also a lot of research out there about resilience and the role of meaning in resilience. If you're interested in that, there is also a prep webinar on resilience. I think it was Michelle Zechner who put that on. She talked about the PERMA theory, and the M in that acronym of PERMA stands for meaning. So there's a lot of research being done on the role of meaning in recovery and resilience. And it's important to remember that the search for meaning is not having meaning. It's a process. It's a search. We're always creating new meaning as we experience new things in our lives. So it's not a once and done kind of thing. And for the second half of the definition, this ways related to the sacred. Sacred is a very churchy word, but it literally means holy or special. It comes from a Latin word that means to set something aside or to devote it for a particular cause. So when we talk about spirituality, we're saying it's about anything that we set aside as somehow different, special, valuable. It's not necessarily limited to just religious items or special rituals, although it can definitely include that. So, we might say something like family time is sacred to me, right? That's something that's sacred. Art and music, we often talk about as being transcendent or special in some way. We may talk about nature or natural land that needs to be set aside and preserved because there's something valuable about that natural space. Next slide, please.
So within that definition, spirituality includes both internal perceptions, including our beliefs and our worldview, and external behaviors, which would include practices and rituals. So with our beliefs and our worldview, beliefs often relate to the big existential questions. Think of this as part of the search for meaning. These questions such as who am I? Why am I here? What matters in life? What happens in the future? So for example, belief in a divine being might answer the question of why I'm here, because the divine being created me. And belief in reincarnation might answer the question of what happens when I die. This can also include our ethical assumptions and our judgments about how people should behave, how society should function. So for example, I believe everyone has a right to food and shelter, or I have the right to do what I want as long as I don't hurt anyone else. These would be beliefs that relate to society at large. We also have externally practices and rituals. So spiritual practices can be easier to identify than beliefs because they're more concrete. However, they can tell us a lot about a person's internal belief system. So prayer demonstrates a belief in some higher power, and going to worship, a worship service demonstrates value in community. So when people hear the term spiritual practices, they often assume an organized religious practice, such as going to church, prayer, meditation, and that sort of thing. But we really want to expand this to include everyday actions that reflect our core beliefs. So if we take a belief such as the golden rule, which is common to many different spiritual traditions, treat others how you'd like to be treated. This can play out in my daily interactions with others. I have worked in catering in the past, so my application of the golden rule when I'm out at a restaurant is trying to be kind and generous to service professionals because I know what that's like to be on the other side of that interaction. So we might not think of these as religious practices, but they are behaviors that express a spiritual belief, so they can be considered part of my spirituality. I lead a workshop for patients on values, and after leading and participating in it myself many times, I've noticed that my top values always includes family as one of the top two, but that it wasn't always coinciding with my actions. So I took that as a realization and an invitation to find ways to connect with my family, who most of whom live very far away from me. That way I could live out that value and have my actions and values be more in line. So thinking in that way, everyone has certain behaviors or practices that reflect their sense of meaning and value, even if they aren't quote unquote religious. Another example is that giving to charity and volunteering. These are practices that directly reflect a deeply held value. So again, that sense of what is sacred, what is special, and so. So now we'd like to invite you to put into the chat what some of your practices and actions are that reflect your beliefs. So what are some actions, some concrete things that you do that relate to a deeply held belief that you have? And you can go ahead and put that in the chat. Yeah, I was just going to give an example, connecting to nature. That's something for me is that I love walking in the woods, and that feels very spiritual to me because it connects to my value of nature, sense of connection with the world, with God, and even feeling a sense of purpose. Oh, these are great. I've seen a lot of good things come through. Yeah. Worship. Yeah. Watching clouds. I saw things related to family, to different actions that people take. Ah, thank you. Feel free to keep on putting things in the chat as you like. Going to move on to talk a little bit about rituals. So rituals are spiritual practices that become formalized within a community. So examples of this would be services of worship, hand washing, or other cleansing practices. Anthropologists and sociologists often study rituals because they give a sense of the values and beliefs of a given culture. And even our secular culture has rituals, even if we don't call them that. So think about a week and a half ago, how we had Mother's Day. There are many rituals around Mother's Day involving cards and flowers and I don't know, maybe even breakfast or baked goods. Greeting cards in general, marking certain days or events as significant. That's as sacred. Think about sporting events and the different rituals around sporting events, the national anthem being sung, a first pitch or a coin toss. So when we say spiritual practices, we're using that in the broadest sense to include both formal rituals and more informal and personal practices. And our assumption is that everyone has them. Can we move on to the next slide?
Just to set the stage a little bit, I want to talk about the relationship between spirituality and psychology, psychiatry in general. They actually share a very common root. I'm kind of nerdy. I like learning about words and where they come from. So the word spirituality comes from a Latin word spiritus, which means spirit or soul. And then psychology, psychiatry, anything with that psyche root comes from the Greek, which means soul or mind. So these two fields are basically addressing the same thing, this core, whatever a soul may be, the core of our life, who we are as a person, whatever is sort of beyond just our biology. That's what spirituality and psychology are both trying to figure out. And I do want to be clear, I do not think that these two fields are identical by any means, just that they share a common interest. We know that psychology and psychiatry are more research-based, they come from a science perspective. Spirituality, on the other hand, is more focused on the experiential and the philosophical side of this sense of soul. So they're different perspectives, but there's a lot of overlap there. There has been a complicated history between the two fields, often hostile towards one another, but increasingly in the mental health world, we're seeing the two fields start to respect each other more and understand value that they bring. And I'm going to talk about that more when we get into some of the deeper stuff with psychosis. So we can go on to the next slide. So when we talk about somebody experiencing psychosis, how is that impacted with their spirituality? Anyone who's suffering from any kind of illness is going to be dealing with these existential issues. Why does suffering exist? Why me? What hope do I have in this situation? That's a common human response to any kind of experience of illness or difficulty in life. It also may have people questioning their previously held beliefs, right? I used to believe this, but now because I'm struggling with this illness, I have different questions. So it's that process we talked about of making meaning as the experience happens. The complicating factor is that meaning making in and of itself is a cognitive process. So when someone's experiencing psychosis and their cognition is affected, that's directly going to impact how they're able to engage with their spirituality. So there's a couple different ways that this can play out. We often see as chaplains someone describing their symptoms in religious language. We get a lot of people who talk about feeling guilty or condemned in ways that relate to maybe depression or to voices that they're hearing. People will often identify their hallucinations as demons, or on the other side, as God talking to them. We also see a distortion of what's otherwise a normative belief or practice. So in the Christian tradition, trying to be more like Jesus is a pretty normative belief, right? We all want to be more like Jesus. But when somebody is, say, in a manic state, they start to believe that they are Jesus. And that's a distortion of that otherwise normal belief. The same thing can happen with prayer practices or any other spiritual practice, right? Prayer is a very normative spiritual practice. But when you have somebody going out in the middle of the street at 3 a.m. screaming their prayers, maybe that's a distortion of what would be considered a healthy practice. We also find people having difficulty engaging with some of the communal aspects of religion. We know that schizophrenia and other illnesses have a lot of negative symptoms that make socialization difficult. And so if somebody even may want to participate in a church, it may be very hard for them to engage in the communal aspects of their own tradition. And then on the other side, we see that faith communities, unfortunately, do still have a lot of stigma towards mental illness. And so somebody who's actively experiencing symptoms may not feel welcome in a communal setting. And then finally, and I'm sure there's a lot of thoughts and questions about this, which I promise we will get to at the end, this idea of preoccupation or fixation, right? Religious preoccupation is a term that gets used clinically. We may see someone who's sort of trying to proselytize others in an excessive way without any awareness of context or social cues, or somebody who's fasting excessively to try to earn God's favor, not allowing any sort of structure or limits to those practices. I think it's really important to note here that religious preoccupation is not caused by, but is also not separate from a person's authentic spirituality. So the fact that someone is religious doesn't make them become preoccupied. That is a symptom of their illness. But also somebody who's religiously preoccupied, that doesn't mean that they don't have an authentic spirituality. It may be distorted in some way, but their connection to what they believe in their spiritual practices is still real and authentic. And so we want to highlight that. And we also want to be aware of what looks like preoccupation to one person may actually just look like devoted faith in another tradition or to somebody else. So we have to be really aware of somebody's cultural context and what is normative in that tradition in order to be able to kind of sort that out. And hopefully the rest of this presentation and our discussion at the end will allow us to really dig into those questions. There's been a lot of research about spirituality and coping over the past few years. There's a Handbook of Religion and Mental Health by Harold Koenig that sort of summarizes a lot of this research in helpful ways. And overall, the outcome of this research is that spirituality has a positive impact on coping. It's complicated to define, it's hard to measure. Obviously, measuring someone's practices is much easier than dealing with those internal aspects, the beliefs and the process of meaning making. But what's found is that it's the quality of engagement, not the quantity, that is more helpful for coping. So how a person is engaging with their beliefs and with their practices, maybe to deal with those questions of meaning or to find hope or to connect to other people, that's more important than whether or not they have, a prayer practice 18 times a day and go to 12 church services, right? So it's not quantity, it's the process of engagement. And even some things that we may think of as sort of maybe negative, or we might have some judgments about in terms of spiritual beliefs and practices, can actually be helpful for someone in terms of their coping, depending on how they're using it. So if someone believes, for example, that their illness is a punishment from God, I have kind of a visceral reaction, like, no, that's not God. God doesn't do that. But if it helps that person accept their illness and be able to cope with it, it could actually be really positive for them. Somebody who believes that their voices that they're hearing are demons, May be able to use prayer as a helpful coping tool to ignore the voices or kind of fact check. You know, these aren't really real. Demons don't have power, only God has power. So how someone's using that belief is more important than the actual content of the belief at times. So it's helpful also to know, what do we mean when we talk about coping? In order to be able to assess whether spirituality is helping you cope, we need to know what is coping. Similar to what Ali discussed with spirituality, coping also has internal and external aspects. The internal piece is in terms of, how does someone understand their illness, and are they able to accept it and therefore be able to manage it in helpful ways? So that's kind of the beliefs piece. And then we also hope that somebody's able to develop really practical ways to manage their symptoms, right? Coping strategies. We talk about that a lot at the hospital. So spirituality is really helpful because it provides a framework for both of these two aspects of coping, right? Spirituality has the beliefs, the internal aspect, and it can also provide spiritual practices that can be really helpful in managing symptoms. Just like we talked about spirituality being a dynamic process, coping is also a dynamic process. I have a quote here from Viktor Frankl: "The meaning of life differs from man to man, from day to day, and from hour to hour. What matters, therefore, is not the meaning of life in general, but rather the specific meaning of a person's life at a given moment." So again, we're looking at, how is a person engaging their beliefs over time? How are they applying them to their particular experience right now? Not just what is their, checklist of beliefs that they may hold. And we find in that process that even religious struggles, asking questions, having doubts, can be a really healthy part of the coping if it allows someone to find a new sense of meaning and purpose in the experience. So we'll move on to the next slide and talk about, what do religious traditions actually offer in terms of these aspects of coping. The first thing is the structure for making meaning. Most religious traditions offer authoritative teachings about these big existential questions. Where do I come from? Where am I headed? What's the meaning of life? There are also a lot of myths and stories in different traditions that really help explain suffering and why things are happening the way that they are. And I found that patients, especially if their cognitive functioning is impacted by their symptoms, may find it helpful to have an external authority to help them make meaning, because it's really difficult for them to sort through these questions on their own. It may be easier to hang on to something that's provided to them in the structure. And we mentioned resilience earlier as well, that this role of meaning making is really helpful in overcoming trauma and dealing with difficult experiences. We also find that spiritual practices can really help with managing symptoms. Prayer, as an example, there's a patient I've worked with for a long time who believes that people are stealing parts of her body, and she will be screaming and terrified and yelling at people who she thinks are taking her body parts away. And she sees one of the chaplains walk onto the unit and immediately calms down and says, "Chaplain, will you pray for me?" And in the prayer, she's able to talk about her experience of these symptoms, to ask for help. She often prays for relationships to improve between her and other patients on the unit. And so in that case, that use of prayer is really helpful for her to cope with that symptom that she's experiencing. We also see a lot of research right now about meditation. It's a practice that's common across a lot of different religions. There's contemplative prayer, there's mystical traditions, mindfulness is a big sort of buzzword for this right now. There's a lot of cool research being done. If you're interested in that, I mentioned Andrew Newberg earlier. He's out of Philly, and there's a woman named Sarah Lazar who works for Harvard, who does a lot of brain scans and studying mindfulness techniques in that way. What I find really fascinating is that these are historically spiritual practices: meditation, prayer, mindfulness. These things are now being studied as clinical tools to help people recover. It's something I'm actually very excited in. Jen mentioned in my introduction that I'm actually working on a book right now on spiritual practices and how they can benefit mental health. So if that's something you're interested in, please reach out to me. I think I will be starting an email list. The book is not due out until next spring probably, but if you're interested, please let me know. And then our final category here is pro-social behavior. A lot of traditions and spiritual practices promote pro-social behavior, right? We have rules and guidelines that we're supposed to follow as part of our religious tradition. So A well-known one is the 10 Commandments in the Jewish and Christian tradition, right? It teaches not to steal, not to lie, not to murder, to be respectful of other people, right? These are helpful pro-social things that we would like to have people be able to do even when they're struggling with symptoms of their illness. There's also a sense of general connection and sort of social responsibility that most religious traditions teach. There's a lot of Buddhist teachings about like the interconnectedness of all beings, which can be helpful in promoting that kind of pro-social behavior. So there's a really complex interplay between spirituality and mental illness. And it really requires, as clinicians and as chaplains, that we do individualized assessment. So let's move on to the next slide.
So with spiritual assessment, one of the things we're trying to assess is how the spirituality of this person functions for them, and whether it's manifesting as more of a healthy aspect of their life, or whether it seems to be less healthy for them. So some views that could be considered less healthy would be having a view of God as being distant or critical, having a sense of one's future as being ominous and a negative sense of oneself, feeling insignificant, having some characteristics of denial in terms of one's own experience, self-isolation, viewing oneself as a victim, or feeling that they are passive in life, and rigidity, holding too strongly to certain beliefs. Whereas more healthy spirituality might be characterized by viewing God as benevolent and loving, having a hopeful sense of one's future, positive sense of oneself, having a meaning and purpose, being part of exploring meaning and purpose, having a sense of acceptance of one's situation, and being able to see reality and one's situation as it is, having a sense of connection with others, feeling some sort of empowerment in terms of one's ability to make choices, and having adaptability and being able to apply one's beliefs in different circumstances in different ways. So as always with humans, things can get confusing, and a person will not necessarily have only healthy or only less healthy spirituality. And so as a chaplain, we try to sort things out, but it can even be confusing for us as we talk to people and try to determine how a person's spirituality is functioning for them. But there are many models of spiritual assessment out there, and one that I have found valuable and have been using recently is called the HARP-M model, and that is an acronym. And while talking to patients, I try to notice from their story which of these themes is really rising to the surface as being more prominent. So HARP-M stands for hope, autonomy, relationships, peace, and meaning. And along with that, there's a severity scale that looks at whether a person's resources are adequate for their need, to really see how they are coping. So the range includes well-being, when their resources are more than what is needed for the need, coping, where it's adequate, pain, where their resources are below the level of need, distress and despair, where one's resources are quite inadequate to the need that the person has. So in addition, at Trenton Psychiatric Hospital, we also assess a person's spiritual practices, and we try to communicate with the treatment team if there are practices that are helpful to the patient that they can access while in the hospital. We also try to get a sense of how these aspects of their spirituality impact their life overall, and particularly their experience of mental illness, and if it applies to them, their legal issues. So here at Trenton Psych, we have a spiritual assessment form that goes in the chart, and when a spiritual assessment is triggered, when it's requested, then we will put the fill out the form and put that in the chart. And assessment is also something that we just do when working with patients, whether it's on the official form or not. It's one of our tasks, but we also spend time helping patients actively work through their spiritual questions and practices that we've been talking about today. This is what we call pastoral care. So when we say for the pastoral care department, this is what we're doing. So next slide. And I saw your question, Margie. There in our resources, there's more information about the HARP-M model, so it will be there for you. All right, so pastoral care is engaging patients in the moment by moment search for meaning using the language and tools of their own faith tradition. So what pastoral care is not, it is not preaching, although you will see us here offering church services where we do preach, but that's separate. Pastoral care itself is not preaching. It's not Bible study unless the patient asks for it. It's definitely not proselytizing. It is not advice giving or fixing. So we're really trying to work with the patient in their own tools and what they have to offer and try to be a support to that and a guide. So a lot of times what work of chaplains focuses on is empathetic listening, reflection and clarification of the patient's own beliefs, and general rapport building. We're really engaging with the patients in the language of their own spirituality. Really believing in that they have the tools, many of the tools that they need, and perhaps we can offer some extra resources, but really trying to build on their own strengths. So chaplains at your institutions may offer something different, but here at Trenton Psych, what the chaplains offer, we offer spiritual assessment, we offer spirituality-based clinical groups, we offer faith-specific worship services, and individual pastoral counseling. Next slide.
So these case examples that I'm going to talk about are based on real patients that we've worked with here at TPH. They are composites, so they are not representative of one particular patient. They're often sort of a mixture of different people we've worked with. And obviously names and details are changed around to try to protect the patient's privacy. I also want to highlight that these particular examples all happen to be Christian patients. As chaplains, we do work with patients of all faith tradition. The majority of our patients here at TPH are Christian, and that's also our backgrounds particularly, so it's easier for us to talk about that in a helpful way. But I would expect that similar and very interesting discussions could be had about faith practices and beliefs from other traditions as well. So the first one I'm going to call Amanda. Amanda was a very well-educated woman who came to TPH after being found praying in her nightgown at the side of a busy highway. She was highly religious, reading the Bible all the time, trying to proselytize other patients, but she would rarely speak to the chaplains. She frequently fasted from food and would defend her right to do so as a religious practice, to the point that she started to have serious physical complications from withholding food. She was very sensitive to any attempt to change her beliefs or practices, but the treatment team had asked that she have individual pastoral counseling sessions. So what do we do with that as chaplains, right? She doesn't want us to change her beliefs and practices. The team does. How do we find that balance? So chaplains who worked with Amanda really focused just on building rapport with her, just discussing her goals, her own sense of purpose. And by sort of validating this sense that she had of having a special calling, being called by God to something particular, they were starting to build some trust. And that helped her explore other ways that she might effectively express her faith without risking her health. So really what the chaplains did was focus on this link between beliefs and practices to try to help motivate some change. That if we hold on to that belief and find a different practice to express it, that might be healthier. That would be a helpful approach. The next one I'm going to call Leo. Leo had a long history of psychiatric hospitalizations in and out of TPH, at least 10 times. Diagnosed with schizophrenia in his 20s and had frequently been non-compliant with medications, in addition to using substances like marijuana and alcohol, which then intensified his psychotic symptoms. He picked up criminal charges along the way related to possession of substances and that sort of thing. When he was at the hospital, he would frequently request to meet with the chaplains. And when he was very symptomatic, he believed he was God. And he would see visions of demons that would speak to him, and he believed that he controlled the entire world. When he would become more stable, he would express a little more ambivalence about this identity, sort of at times still saying he was God and had the power to condemn people to hell if they didn't do what he wanted, but also asking chaplains to pray for him. So praying to God on his behalf, which is a very interesting switch of perspective there. So rather than trying to contradict his religious delusions, the chaplains really focused on that underlying need that he was expressing to feel control. As a person with severe mental illness in and out of institutions, he didn't have a lot of control in his life. And so this belief that he was God helped him feel a sense of control. And so by giving him a little more empowerment over small choices in his life, the chaplains could give him that sense of control so that he didn't feel as much the need to insist that he was God. And sometimes it even became kind of a joke between him and the chaplains. So just by connecting to those deeper spiritual concerns of meaning and control, you can approach the situation from a different angle and not directly engage the delusion itself. The last one I'm going to call Maria. Maria was a young woman diagnosed with bipolar 1, most recent episode manic. She had a history of non-compliance with her medication. She was found wandering the streets, disorganized, grandiose, and even assaultive at times. When first admitted, she asked to meet with a chaplain, but then would become verbally aggressive, threatening the chaplain, accusing chaplains of working for the devil, and not really wanting to talk once the chaplain actually showed up. She did respond well to medication. She became more reality-based and less aggressive during her time at the hospital. And so her treatment team was starting to look for housing and preparing for discharge. And then they got a report that Maria was in the chapel room here at the hospital, playing on the keyboard and singing what seemed like a made-up language. And some of the staff were very concerned about this. Now, the chaplains had gotten to know Maria over her time and knew that she came from a Pentecostal Christian background. And in that tradition, singing in tongues is a normative spiritual practice. So when the chaplain went to ask her about this practice where she was playing the keyboard and singing, she shared that it reminded her of her church back home and that it helped her to feel connected to that community where she had felt very loved and supported. And so understanding her cultural context and the spiritual practices of that context was really important so that the chaplains could come back to the team and say, no, this is actually a really positive thing that she's doing. It's not a sign of her symptoms coming back. She's trying to reconnect to her community in this way. So it's worth saying that in none of these examples did the chaplain cure the person's psychosis. That is not what we do. We don't fix problematic behaviors. Spirituality is only one part of a person's recovery process. And our chaplains worked with varying degrees of success with patients like these to try to help shift them in some way towards healthier expressions of their own beliefs and practices. So we're not necessarily trying to change their beliefs, but just to shift them any small amount towards a healthier expression of whatever their spirituality is. So with that, we are going to open it up for some questions. I know quite a few have gone in the chat, and I think that Dawn has been keeping track of them for us. And if you have additional questions, please type them in the chat now, and we'll happily discuss.
Thanks, guys, ladies. The one question was from Margaret, and she wanted to hear again the HARP-M, what that acronym stood for.
Yep. So, so like I said, we do have it in the notes, but I'll just go over it again. That stands for hope, autonomy. Autonomy really getting at a person's own sense of their ability to make their own choices and affect their own life, relationships. So, but getting at connections with others, peace, and meaning. So those are the 5 categories that that model looks at.
Thank you for covering that.
To discuss any other questions anybody has about working with patients who have spirituality and psychosis that are both interplaying in their lives.
So there's one here. Do you think spirituality can be a coping skill? Absolutely, yes. It goes back to, I think, what I said earlier about how a person is engaging their spirituality, right? Spirituality can be helpful and it can also be harmful depending on how it's used. So it's not a one-size-fits-all answer, but absolutely it can be a positive coping skill for many, many patients. We have a comment about patients loving the yoga group. One of our chaplains here offers yoga groups in a couple different parts of the hospital. And I love yoga as a spiritual practice because it incorporates both the sort of internal thing, what we're thinking about, what we're focusing on, along with the physical practice. So I think it's a great way to kind of work on both the internal and external practices at the same time. As a chaplain, I work with patients who talk about deeply held religious beliefs that are unable to follow the practices of their faith due to their symptoms. Yes, that is a complicated scenario, especially here in the hospitals where there's limited access to certain religious beliefs and practices, depending on, you know, whether, you know, certain items are needed for a practice, or if it just not being connected to your home community. It's very challenging for patients. And then the ways that symptoms can get in the way of those practices. It's very problematic.
Yeah.
Say more.
Well, one thing that we try to do in like our spirituality groups or worship services is try to provide a place for people to engage as much as they can. So even if a person is very symptomatic, as long as they're appropriate in group, we try to make space for them in those spaces. So it is very challenging, and that can be very difficult when somebody, it's a very important part of their life, and yet they can't access it because of their symptoms, whatever the symptoms might be. Yeah, so I guess I'm not offering too much other than to say we do try to give space for people, however symptomatic they are in groups.
And it may be a time when a patient is expressing some grief over the fact that they can't, and that's something that we might help them process, right?
Yeah.
A sense of grief that they can't be a part of their community, or that they can't practice in the way that they would like to.
There's one question, ladies, in the Q&A from Stephanie, and the question was, I just didn't want it to get lost from the chat. It was, could you speak to the potential for spirituality to become maladaptive in patients experiencing psychosis?
Yeah, again, it's that question of how is the belief being used, right? So if somebody's spiritual belief makes them not trust the people who are trying to care for them, for example, that's going to be more problematic, right? And how do we work with that? And what is the underlying issue there of not trusting people? And can we work on that issue so that they can express their spirituality in a healthier way? So it's that individualized assessment that's really key to figure out, how is this belief functioning for this person? How are these practices functioning for this person? And can we offer them something that is still true to their spirituality, but is a healthier version of that expression? Did you add to that?
Yeah, well, we might just really focus on rapport building with someone like that. I mean, I'm thinking of some patients who really don't like working with the chaplains, but who believe that they are God or something like that. And we can't just waltz in there and just develop a relationship like that. Like, we really have to work very gradually, because a lot of times there is a lot of mistrust there. So definitely it can be a maladaptive coping, and we as chaplains try to shift that even ever so slightly. I see that Tom wants to know if atheists can talk to chaplains. They sure can. Had some wonderful conversations with atheists, because everyone has answers to those existential questions, whatever that may be. And chaplains are people who are very interested in talking to people about those questions, whether the answer to, is there something greater than me, is no. You know, we'd love to still talk to that person. So we're not trying to change anybody's beliefs, but to work within their framework that they have, and try to help them perhaps access or utilize it in a more effective way.
Yeah, there is actually such thing as atheist chaplains, who are atheists, self-identified atheists, but who understand these things about spirituality that we've been talking about today in terms of meaning and purpose and spiritual practices, and use that to help other people, even though they may not believe anything themselves. That's very interesting. We have a question about scrupulosity, religious OCD. Is this something we've seen? Does it sometimes lead to psychosis, or does psychosis get mistaken for this? For me, it's always both and neither nor. I don't think that religiosity can create this and can create psychosis. And I also don't think psychosis means that the person is not authentically connected to their faith tradition, right? It's a distortion. So the faith is sincere, and the illness comes in distorting that faith in such a way that it causes problems. One of the key standards for whether a person gets hospitalized or not is, are they a danger to themselves and to other people, right? So is this religious scrupulosity, these obsessive practices that they're engaging in, is it harming them in some way, or is it harming other people? And if it is, then it's something that obviously needs to be treated and needs to be worked on. If it's not, then who am I to judge?
No, no.
There was a question that came into the host and panelists, so I'm not sure if you ladies saw it, but It was, how do you handle patients that think that the medication that they're being prescribed comes from somewhere dark?
I
Or
mean,
have you ever encountered that with patients who may be resistant to taking medications and may attribute it to something, you know, evil or dark or controlling?
sure, or even like patients might even say that it's just not like a faithful response to take medication because they have to believe that God will heal them and they need to use prayer. I mean, that is something that we've seen before too. I try to really focus on some concrete and practical things with the patient, like how they're getting along with the treatment team, whether they trust them, whether they can like work with the team. So I'm trying not to focus on just like the meds as the main focal point. I think that can just create a lot of resistance in the relationship. So again, trying to keep up rapport and trust, validate what I can, while also seeing where the patient's goals align with the team's goals. Also, like looking back, okay, what has it been like when you've been on medication in the past? Sometimes people could say, oh, well, when I was on meds, I didn't like it, but like I was able to sleep better, or I didn't hear the voices as much. Or they might be even able to own that the meds have helped them in the past, and that can lead them to come to a decision to take the meds. But really, again, focusing on rapport building, relationships, and trying to help the patient see how their goals and the team's goals can align to really work together, like that therapeutic alignment.
Yeah, and like motivational interviewing techniques too, right? Of helping explore what is it that the patient doesn't like about medication, right? Why do they think it's dark and scary in some way, right? What have they been taught by their faith community? And are there other sources that we can share with them just to balance out that perspective a little bit? But it's tricky because our goal is not to change their beliefs, and yet we can see it's negatively impacting them. So it's tricky.
There is another question in the chat. Could you say more about how a chaplain would approach maladaptive religiosity versus a different treatment modality? So what's the approach a chaplain might take versus another clinician?
Well, I think one thing that chaplains can bring is that we have studied theology, faith, religion, oftentimes more in depth our own faith tradition and our own religion. And so one thing that we can bring is a little bit more of a sense of being kind of alongside the patient in terms of like their spiritual quests. I don't think that this is exclusive to chaplains, but it is one strength that we have, is that we are often seen as an ally in this, as not having another agenda. So one thing that I think, like one approach we might have is trying to come alongside. Yeah, we're not outside the treatment team. However, the patients may see us more as an ally in terms of spirituality because that is our function. So I would say I do use a lot of treatment modalities that anybody could use, such as things from DBT I have found very useful in my work with patients, motivational interviewing. These are things that any clinician can use. And yet being a chaplain sometimes just gives us a little bit of an edge in terms of developing that relationship.
And I think in some ways, you know, also answering Tom's question about whether we're outside the treatment team, we are a part of the treatment team, but I think our goals are different. So in the same way that, you know, a psychiatrist has a different lens and maybe different goals in terms of medication than a psychologist whose goal is working on, you know, thought process and behavior. A chaplain is looking at the spiritual goals as well. So what does this person believe and what do they need to help them make meaning of their experience right now, right? What resources can I offer them to help them find that meaning in a way that's more adaptive? So it's a different lens in the same way that a team is made up of a lot of different people with a lot of different expertise and different lenses. Our lens is much more focused on those existential questions and less on specific behavioral targets.
We have a question in the Q&A also from Matthew. Are there groups that you found fruitful for spirituality led by chaplains? And what did they focus on, or what were they called?
I'll start on this. I've led spirituality groups in a number of different psychiatric settings. So like here at Trenton Psych, but also at an inpatient unit at a medical hospital and in an outpatient psych setting as well. And I have found a couple of different types of groups to be very helpful. One is like a workshop model, which focuses on different topics, such as the one I mentioned, values, And that the values workshop is very simple. I could, because it's one question, what is important to you? What are your values? And I just feel like if I have a whiteboard or a blackboard, I just fill it with their answers. What do you value? What's important to you? And get 50, get 100, however much space there is. And then ask for people's top values and how are their actions connected to their values. So that's an example of a workshop taking one topic and then asking a couple of questions to really dive into the values. There's ones on forgiveness, self-esteem, all sorts of topics. We also have sort of a workbook model where we have different topics that chaplains have created over the years and go through it. That's a little bit more like kind of like a class or didactic, reading different paragraphs. I've also done spiritual practices during spirituality groups. I've also had mindfulness that answers the question about what I found many things useful from DBT, but one was mindfulness. And so I've done a series on mindfulness to focus on the present moment in different ways. And in spirituality groups, always being open to people of all faiths or no faith. So that is one that's really open to any patient who is just willing to engage in this.
Yeah, one series that I found really helpful that really engages a lot of patients is talking about different religious traditions. For some patients, if they were raised in a particular faith or even a particular branch of that faith, to learn that other options are out there can be really helpful for people, or just to learn how to engage with somebody who has a different belief. So often in spirituality groups, we'll set ground rules, right, about how we show respect to each other. And that helps patients learn, how can I hold my belief and still respect that somebody else has a different belief, and I don't need to change that and they don't need to change me. So just engaging in sort of general knowledge about spirituality can be really helpful. I also lead a lot of the mindfulness groups, and they're very experiential. So we do a lot of like sensory activities. A couple of weeks ago, I brought in some stones and had patients feel the texture of the stones, and just we spent 20 minutes talking about little rocks, right? Like it's a very experiential, present moment based experience. We do breathing exercises, relaxation techniques, things like that as part of our mindfulness group as well. And I also have to speak to the DBT thing because DBT is my heart. I've been a part of the DBT program when we had one here at TPH, and there is so much about the philosophy of DBT that I think aligns with the philosophy of chaplains and with my own personal spirituality. The biggest piece being accepting someone as they are is necessary in order to help them change. You have to love and accept the person where they're at right now with no judgment in order to help them change. And I feel like that philosophy is something that we as chaplains bring to basically every encounter. We're meeting you where you're at, and we're also hoping that you will grow and hoping that you will learn and enjoy your life in new ways. So that's something that I bring into almost all of my work as a chaplain and in life in general. Once I talk about when we train our students, I sometimes talk about DBT and I say that I have drank the Kool-Aid of DBT. So like, I can't not talk about it from that philosophy because it's where I'm at. But that's me. Not everybody drinks the Kool-Aid, which is okay. I respect your beliefs that you don't buy into DBT. Yeah. Any other questions that we missed?
I don't have an answer for that very specific question about Brooklyn.
So we have about 2 minutes left, and I want to make sure that Dawn just posted the training evaluation. And as I mentioned earlier, there's a list of not only the handouts, but a list of resources. This list is available in the training evaluation with active links. Somebody had a question earlier about where we could get that information. There's also a list of references that were used in the presentation. So if you needed to find them, you can download the handouts that have that information in them. And again, you can get a certificate of attendance, and this will be available. The recording will be available tomorrow on our website that Dawn posted earlier. So with 1 minute left, if there's
somebody asked a question about how to find a chaplain at a specific facility. You would have to reach out to the facility. It's very hit or miss. Some facilities have a whole chaplaincy department. Some people run it through volunteers. Some people will have like local clergy who come in and offer spiritual care. So you'll have to reach out to that facility, and maybe in their patient services department, you might get an answer about how you would contact a chaplain. Most major medical centers will have a pastoral care department, but psychiatric facilities are more hit or miss.
And I just want to say, if there's any other questions anybody has, anything lingering that we didn't address, please do reach out to us. And we are happy, there's our emails and our phone number. We are happy to engage with anybody on this topic.
Well, thank you.
There's a
And
typo in
like-
my email address, but. Miriam is good.
So this is Ali and Miriam's email. And if anyone has any problems getting through to anyone, you can contact Dawn or myself at the IPPER email, and we'd be happy to connect you. So ladies, thank you so much. This was an amazing webinar today. Thank you all for joining us. Please stay tuned for information for our webinar in June, 3rd Tuesday of the month, 3 o'clock as usual. And thank you for being here, and thank you for the presentation today. See you all next month.
Thank you.
Thank you, everyone.